Hello, my name's Tracy Green. I'm the clinical manager from Sigvaris Group Britain, and I'd like to welcome you all. Good morning, good evening, or good afternoon, depending on where you are joining us from. This is our latest MOH session, which is on lipedema, a multidisciplinary approach. And I think we all can understand that from a lipedema point of view and management, we do need to have a multidisciplinary approach so that we can manage these patients effectively. I'd really like to welcome joining me today in moderating this session, Dr. Mohammed Omar El Farouk from Cairo, a highly experienced and specialist vascular consultant. So it's really lovely to be working with you again. Welcome, and I'm going to hand you over now to Dr. Omar to continue the session. Thank you. Over to you.
Thank you very much, Tracy, for the kind introduction. I'm really honored and very pleased today to be part of a global expert ring in a very recent field of lipedema. I guarantee all the attendees will enjoy a very fruitful couple of hours that sure will have a lot of new medical knowledge and medical advice. Let me present our two excellent global speakers and two excellent global panelists. We are trying to squeeze about 100 years of expertise in different continents. So it's very enjoyable. The first speaker from Brazil is Professor Fabio Kamamoto from Brazil. He is a previous president of General Surgery and Plastic Surgery Hospital of Das Clínicas de São Paulo. He also has a master's degree in plastic surgery. He give a lot of impact on the cosmetic part of this disease. He also have a PhD in very interesting topic of healing in 2017. He has a great experience in multiple fields of plastic surgery, and one of that field is lipedema. He's also a full member of the Brazilian Society of Plastic Surgery. Our second great speaker is Professor Thomas Wright from United States, and he's very well known in lipedema field from his great research and great new ideas. He is a medical director of Laser and Vein Center in United States. He's one of the first to have a diploma from the American Board of Venous and Lymphatic Disease. He's also have authored and presented several papers in the new surgical techniques of venous disease and venous insufficiency. And he has received multiple awards about his new innovation. And I guarantee he will add a lot of the knowledge and the expertise and the future in that field. I'm also delighted to present our two great panelists. First one from Germany, Dr. Gabriela Farber. She has graduated from a school in Heidelberg, and she also have experience from South Africa. She had a scholarship from the German National Academic Foundation and from city of Mannheim. She's also an experienced phlebotomist in Hamburg. Over 20 years, so she will give us a great reflection from her vast experience with this disease in Europe. She also has been involved in the German guidelines on that disease from the German Society of Phlebology. I'm also delighted to have a very dear colleague from India, Dr. Pavitra Radhi, very well known experience in physiotherapy of that disease. She has been graduated from RV College of Physiotherapist, and she had a master's degree in Obs and Gyna physiotherapy from Manipal University. She is certified CDT consultant, complete decompression therapy, both our limb, lower limb, difficult cases of the neck, and multiple field. And I always said I've learned a lot from physiotherapists, especially in this lipedema field. He also worked in a private center of lymphedema in Bangalore. Having said that, I'm delighted to have all the attendee. We would like to have all your questions. Either you can put it on the chat, you can put it on question and answer button, or you can raise your hand if you want to voice. Always say this global network is always enriched by your participation. We prefer your question to be in Q&A because this time we all can see it and we all can reply for it. And I'm very eager for your contribution. So the mic now will be to our first speaker, Professor Fabio Kamamoto in Brazil. The mic is yours and we are all ears.
Hello, thank you very much for the invitation. It's really an honor to be here with you. And I'm going to be speaking about our experience here in Brazil and a very practical idea of how to treat lipedema here. So I'm going to share my screen. Do you all see the presentation? Is it okay? Is it okay,
Yes,
Dr.
it's
Omar?
okay.
Yes, okay, good. So
Okay.
thank you again. I'm a plastic surgeon here in Brazil. And my story with lipedema started 10 years ago when I first met this young lady. Talita told me a sad story. She told me that she was very annoyed about her small waist and fat legs, and she didn't manage to deal with that. She had often bruises, heaviness on the legs, often pain, and it got worse after the use of contraceptives. And it caused a lot of emotional stress and a feeling of guilty. And she told me that she had lipedema, and that was the first time that I heard that word. And she asked me to do a liposuction on her legs. And 10 years ago, especially in Brazil, it was a very initial experience. There was not much literature about that, but we did it. So that day we took out 5 liters of fat from her legs. This is the day after the surgery. And surprisingly, she told me that her life got better. She had less bruises, less heaviness on the legs, and it improved the quality of life. And it was very, very special and very interesting to me because it was the first time that I started thinking about liposuction as a tool to improve the health, to improve the function of the legs. So it really changed my view about my profession. And since then, I've been working almost every day with lipedema. So what's lipedema? It's a disease. It's a chronic disease from the adipose tissue. It's characterized by the disproportion about the position of this fat. It affects the extremities, the lower limbs, the upper limbs, and also cause a lot of emotional impact. Although it's very, very common, it's believed that it affects 10% of the adult women in the world, which is about 10 million women here in our country. And it has only been recognized as a disease by the World Health Association since 2019, and it was adopted here in Brazil last January. So now we can officially say that lipedema is recognized as a disease in our country. And unfortunately, it's not known by many patients, even by the health professionals, and it's not covered by our public health system. So the diagnosis is based on the story of the patient. She always complains about pain, about something that goes to the legs, but spares the hands and the feet. That's why they have what we call cankles. They often have hematoma formation, and the size of the legs doesn't shorten even with weight reduction. That's why it's very stressful for these patients. It's not yet fully believed the causes of the disease. We often see that there is a genetic predisposition. So 60% of the patients have a relative with lipedema, but the onset is caused by hormones. So there is a strict relationship with estrogen, and it worsens with lymphatic, blood capillaries, and inflammatory crisis. It's divided in 5 types. In type 1, it affects the navel and the hips. In type 2, it goes from the pelvis to the knees. And in type 3, it goes from the pelvis to the ankle, so the whole lower limb. In type 4, it affects the upper limb. And in type 5, it takes only the cuffs. But what's stressful for the patients is that it's a chronic and progressive disease. So from time to time, it goes from stage 1, which is the volume, to stage 2, where we can see walnut-sized nodules on the legs. And in stage 3, the skin starts being compromised. There is the formation of the thighs and the legs. And finally, the final stage of the disease is stage 4, where we can see the lymphatic damage also. So it's progressive, and it's very stressful to see, for example, for a patient, a young patient, that her grandmother is in stage 3, for example. So the treatment is basically divided in 2 pillars, what we call conservative treatment. And that's why this speech is very, very important. I believe that the aim is very close to our objectives, that to make a multidisciplinary approach, because what we need, in fact, is to try to change the lifestyle of the patient, either to reduce inflammation, less pain, less bruises, less heaviness on the legs, either to prepare this patient for a later surgery, and after the surgery also to keep their long-term results. So we always try to work with the lifestyle of this patient, which is a simple idea, but in practice, it's very complicated to improve. And so the pillars of the treatment are an anti-inflammatory diet, regular physical activities, especially low-impact ones, when possible, to avoid sex hormones, because estrogen and progesterone is the trigger for this disease. And some supplements that are still under study, and it's not fully comprehended and fully proved that they have actual effects on the disease. So, of course, that it's not done only by me. So in our institute, we have 2 vascular surgeons, we have endocrinologists, nutritionists, and also physical therapists. So I'm very thankful for this team, and I'm going to speak a little bit about each of us. Claudia is our nutritionist, and our idea is that lipedema is an inflammatory disease, and inflammation can be managed by healthy habits. And our typical Western pattern of diets is a lot of sugar, a lot of fat, a lot of artificial products, and it worsens the inflammation. So one suggestion is to adopt what we call Mediterranean diet, which is based in whole grains, in nuts, more vegetables, to try to substitute the butter for olive oil, fish, and less meat, less fat. So this is less alcohol, of course. And it's interesting, this is a 2021 study, trying to understand the effect of this diet on these lipedema patients. So the study started to improve the 40% of carbo, 30% of proteins, especially vegetable proteins, and 30% of fat. And the 29 patients studied with a plant-based diet with fruits, whole grains, and vegetables, less sodium, and 25 grams of fibers, showed that they had less pain, less swelling, a reduction of the fat on the legs, but a maintenance of the muscle mass. So we all should adopt this kind of idea, but especially the lipedema patients are very happy with this diet. This is our physical therapist, and she works with clinical therapy in order to reduce pain for these patients, in order to modulate inflammation, to manage edema, and of course also to improve aesthetics. And this is a very connected to Sigvari's work, because she used a lot of techniques that is in line with your products, So she works with drainage lymphatic, intermittent pneumatic compression, biomodulation. So these are some examples. There are some light wavelengths that improves the leg, reduces the inflammation. So this is an example. This is what they call in dermology, it's a kind of maneuver to free the fascia from the muscle, to release the fascia and improves the inflammation. They also work a lot of pulling out the fluids by drainage lymphatic, especially after the surgery. Bandaging, which is also in line with your products, wraps, bandaging, and intermittent pneumatic compression. So this all gives a better quality of life for these patients. We are going to have Dr. Thomas that are going to show us a better example of this. This is our endocrinologist. Andrea works with obesity. I'm going to be very stressful with this idea that obesity is not lipedema, but sometimes they are together in these patients. And he also works with hormones orientation. So these are different conditions, in fact, and there are a lot of prejudice over these patients because lipedema is completely different for obesity. This is a very strong case with an American patient that has anorexia, has bulimia, and she still kept the fat of her legs in spite of almost dying of hunger. So she does a lot of campaigns in internet saying that we must, in fact, differentiate lipedema from obesity because it causes a lot of stress with no work for these patients. This is another patient of mine, which was working out 10 times per week, every morning and every evening, making training. She managed to eliminate the fat from her abdomen, but her leg didn't respond to that. And finally, this is another patient of mine that lost 35 kilos of fat after the bariatric surgery, but she still kept the fat from her legs. So this is a condition that we have to stress. And this is something that causes a lot of stress to the patients, that they feel that they're guilty to have this disease, and it's not. It's a genetic disease that's answering to hormones. So there is no problem with her style in these extreme cases, but with a disease that it's not their guilty. And this is our vascular surgeon, and we often work together doing the surgery at the same day. So often Victor starts the surgery by working with the varicose veins. He does the varicose vein surgery. And just after, we start to remove the lipedema by the liposuction. So the surgery of lipedema is done by this journey. The patient starts by doing the diet, physical activities, but unfortunately, it's usually able only to remove 10% of the fat from the legs, a 10% reduction. After that, when the patient has this established, we oriented her to go to the surgery, where we can remove up to 40% of the volume of the legs. And then the patient goes back to the diet and goes back to the physical activities for her life. And according to the last year's American guideline to treat lipedema, the surgery is the only available technique to remove these abdominal cells. So what we believe is that we should join these techniques, the conservatory treatment and the surgery, to have the best results. These are some studies that stress the paper of the surgery. So this is an American study from 2021 with 128 female patients. And a lot of them reported a better quality of life, 86%, better mobility, 96%, and of course, volume reduction after the surgery. And there are also some bridge studies. We follow up for 80 years, Dutch studies also, showing that these good results keep for life. So even after 8 years of the surgery, the patient refers a better quality of life, 84%, better objective improvement, less pain, less bruises, and also subjective improvements. So what we do is a surgery, big proportion liposuction, like in this case, where we worked on the legs. We do a technique that's called lymphatic sparing technique, which is to use small cannulas in a movement parallel to the leg in order to avoid damage from the lymphatic. And this is just a curiosity, but due to the nodules that they have, the fat, we have a lot of obstruction on the cannulas. So even the more the patient has fibrosis, the more they have nodules. So it's difficult to do liposuction sometimes because there is a lot of obstruction of the cannulas. So we have to keep cleaning it every time during the surgery. That's why we finish the surgery by manual removal of the fat, because these nodules are so big that the cannula cannot remove it. So at the end of the surgery, this is when we did the surgery on the left leg and not still on the right leg. We removed the 80 liters of fat. These are the nodules. And this is the result after 3 months. I believe that the removal of the fat improves, of course, the shape and the weight of the legs, but the skin laxity is a problem on the thighs. So we see often this problem of the skin. That's why sometimes we have to work with technologies to improve the production of the collagen on the legs. There are some technologies that are doing the augmentation of the collagen production by heating the skin. This is an example with laser. We are heating the skin, monitoring the temperature with a thermal camera to avoid burns. And in bigger cases, in like stage 3 lipedemas, we have to remove the excess of skin and do bigger liposuctions and also laser. So in a case like this, we do all we have. This is, for example, an 8 liters of fat removal, 3 kilos of skin removal, laser. This is the result after 3 months. And then we went back to the surgery to work on knees and legs. And we removed 7 liters of fat from the legs. And this is the result after 6 months. So a 20 kilos removal from the legs, from the lower limbs. Some cases, the result on the legs, 5 liters of fat removal. The result after 1 year. That's why they say that their life has improved the quality of life, because they feel more normal. You see, they can use boots, they can use some shoes that they couldn't use before. This kind of patients has a lot of stress because it's impossible to take a bus, it's impossible to take a plane with this kind of shape of the thighs. So an 11 liters of fat removal from this to this result, and then again another surgery. So it's stepped surgeries in bigger cases, almost 10 liters of fat from the legs and the knees, and to reach this result. So we founded the Lipedema Brazil Institute because it's a very, very big problem here in our country. In fact, this is the first institute focused on lipedema. And our mission is really to transform this reality of these patients here, because it's said there is no knowledge about this, there is not specialized treatment for these patients. So we work on assistance, of course, but also education. That's why I'm so thankful for this opportunity today. And also I'm very proud of our social transformation program. So as I said, we have a multi-specialty team. So the speech goes with our philosophy of work. We also work on research and education. I'm very happy to inform that this publication was done last week. So showing the lymphatic improvement after the surgery. So this is interesting to see that the surgery may also work on the lymphatic system, not only on the fat of the patient. And I'm very, very thankful to Sigvaris for the support, because you're working very much with our NGO. Our NGO is working with the education for the patients, trying to fight for the right for these patients, and also offering free treatments. So this was a campaign that we are doing. It was last week's photo from a park from São Paulo, where we are going to try to show the population that there is something called lipedema. We managed to join 200 people at the park. And this is our next patient that's going to go to do the free surgery. Tamiris is a warrior. She does CrossFit every morning in spite of her 200 kilos of fat. And thanks to Sigvaris, we are going to do her free surgery next month. She has a stage 4 lipedema with the lymphatic damage on her legs. So as a conclusion, I'd say that the most important mission that I believe is still to do the awareness about lipedema. It's not well known by the health professionals. It's very little known in our country. So we are really fighting to democratize the access to the treatment here in Brazil. We are trying to do the access to our public system for the lipedema patients. And I'm very thankful for the opportunity to show my work here. And we are very hard trying to spread the knowledge and the training also for health professionals. So thank you.
Thank you very much, Fabio. That was really great presentation with great cases and a great strategy. And I hope to have the impact of my co-manager and my panelists and my speakers as well as audience. But let me start first by poll question that will ask all the attendees. This is the poll question. And I will say different treatment modality are included in the multidisciplinary approach for lipedema, except anti-inflammatory medication, physical exercise, excessive sex hormone dosage, and diazepam. So which one of these 4 options is not correct? Please put your vote, and we'll see the result shortly. And we have another poll question, and then I will take the opinion of my co-moderator, my panelists, my speakers as well. It usually take about 30 seconds to collect all your replies. And the answer was in the lecture. It's a beautiful lecture by Fabio. So 60% got the correct answer, which is very good, because sex hormone is not work with your advantage. You should avoid them in conservative management. So if we take the other poll question number 4, in Mediterranean diet modification has several advantages, excluding it can help you to have less pain. It will help you to have less swelling. Patient will not develop cancer, and it will keep your muscle mass. So which one of these 4 are not correct? Again, we'll give 30 seconds. It's a fascinating lecture, Fabio. I really congratulate you on your teamwork, your result, and your strategy.
Thank you very much. I'm trying to develop this system here in Brazil. So this is something that we should do worldwide.
Absolutely, absolutely. And that's why this is a global Sigvaris group talk. And hopefully this will encourage you, all of us, to pull in one direction.
I think in the UK as well, we have a few issues where NICE have said that more research is needed into liposuction for lipedema. And we're finding a lot of our patients are going abroad for surgery because they can't actually access it in the UK. So I do think the more research we can get, we can actually start getting the National Institute of Clinical Excellence to take notice and really push forward for surgery in the UK.
Excellent, excellent. That's true.
Really good.
So the poll question, 71% got the answer correct, because this modified Mediterranean diet does not prevent you from having cancer. So thank you very much. I would like to, first of all, get my co-moderator, Tracy, your feedback about the lecture. I think it's not covered by NHS to have lipedema treatment. That's why they go abroad, because it is expensive to do the operation in UK.
Exactly. I think what's happened was they did some research, or they did some literature searching, some systematic reviews, and found that they didn't think that the research was substantial enough to be able to make a judgment to say that yes, liposuction should be available on the NHS. It is available for lymphedema, but again, a lot of it's done privately because a lot of the clinics aren't able to offer it on the NHS as well due to costs, etc. So I think, you know, there is a lot more that we need to do. We need to bring forward the results from the research, you know, not just from the images, but also from the patient's perspective and psychologically how it's affecting them, what results it has, what quality of life improvements they are getting following the treatment they're receiving. So yeah, the more work you can do, Dr. Fabio, the better, please.
Yeah, excellent. And the speaker, Professor Thomas Wright, do you like to add your very valuable feedback? You're muted. Probably you need to unmute.
Well, Dr. Kamamoto, that was lovely. That was just a great talk. It really will dovetail well with what I have to say, but yeah, a comprehensive approach, and then and very excellent work with the surgery. Yeah. Excellent.
And Gabriella Farber, I'd like to very excited to know your views. You've been treating this condition 20 years, and how is the situation in Germany? Is it reimbursed or not?
Yeah, I just want to start with thanking Fabio for his excellent presentation. I agree with almost everything. I'll have a big comment in a minute. I asked directly to the question that you posed concerning the reimbursement or the coverage. As you might know, Tracy, there's an ongoing RCT in Germany. The results are expected, unfortunately, later than we thought they would in 25, end of 25. And the reason for that being that there have been monocenter studies that you know, like Schmeller and Rapprich and Corneli, but they were not deemed sufficient for the equivalent of the national health system. We've got a different system to cover them. So now we are having this study, and we hope by the time the results come out, it will be clear that liposuction is the more efficient, because they compare conservative versus liposuction, of course. The trouble is that normally when something like that is done, it will be reimbursed, but at a very low financial level. So I'm afraid, I'm very much afraid, that those who are experienced and know how to do it, have known for years, they probably won't be able to do it but we'll have to see. My few comments on your fabulous presentation, Fabio, are that I think I must say, I have been most impressed by your clinical cases. We don't see cases like, for instance, the last one, you said the one that is going to be operated on as your next. Cases like that very often. That brings me to my point. I think there might be a difference in ethnicity also, to whether they develop these huge amounts of fat. Normally in Germany, what I would like to stress for everybody to tell their patients is that when a young girl is seeking your advice, you shouldn't tell them that it's necessarily progressive. There's a lot they can do. And the most important thing, of course, is to keep their weight in a normal range, although, of course, the BMI is not a good tool to judge that. But to try and, I have had girls crying because they looked online and saw those pictures and they thought they'd all look like it. So that's my first comment. It's not necessarily progressive. The weight is progressive. And then, as far as Mediterranean, you know, I've been doing nutritional therapy of lipedema for 15 years now, and my experience is that it is really very, very good and very wise to use an anti-inflammatory approach. But I don't go along with the type of Mediterranean diet that you showed, because my experiences, and this has been confirmed by studies in the United States, in Norway, and in Italy, actually, that it is much more efficient to cut down the carbs, to go on a very low carb diet, and combine that with the anti-inflammatory approach, because carbs by themselves are pro-inflammatory. Insulin resistance is pro-inflammatory. So if you reduce the carbs, and I always call this a reset trial, you know, for my patients, then we can reduce symptoms even more, and then we can find out after we've reached the optimum, we can try what sort of carbs can they tolerate. My last point is, as you said, it's very important to stress the point that lipedema doesn't cause obesity, and that causes lipedema. There's a strong opinion in Germany at the moment, colleagues of mine who really reduce it to psychological problems and obesity, and that is the wrong approach. That is something one has really to state clearly. And about the bariatric surgery, there is a small study on patients who underwent bariatric surgery. They lost a lot of volume, sometimes 50 kilos, but their symptoms didn't decrease. So that is another point. And again, I'm contradicting some of my German colleagues who say it helps. And I think Tracy knows whom I'm citing. It has to lose volume, doesn't decrease the symptoms. That's my last comment. Thank you very much. And I'm very honored to be able to give my opinion here. And I look forward to Tom's next presentation.
Thank you very much. That is great, very valuable point that you enlightened us. And our dear co-panelist, Dr. Reddy, do you like to add your comments?
Hello, everyone. First of all, I would like to thank Dr. Omar for the kind introduction. And I would also like to thank Sigvaris for giving me this opportunity to participate as an expert panelist. Now, I would like to thank Dr. Fabio for such an informative presentation. I would really appreciate how he included patients with lipedema and obesity, as well as lipedema and anorexia. That is something very rare, because usually whenever we talk about lipedema, people only consider obesity as an associated factor. But here he also included patients with lipedema as well as anorexia. That was really nice. So I have a few comments from a physiotherapist perspective. So as Dr. Fabio rightly included, complex or complete decongestive therapy, it is an integral part of the holistic approach or the multidisciplinary approach for patients with lipedema, and more so in lipolymphedema. As we all know, CDT has 4 components. If I have to mention few comments according to the components of the CDT, when we start MLD or when we start with compression garments, it's always better to start with something that is low pressure, considering their symptoms of pain to palpation. since they have a lot of tenderness, it would be great to go slow. And another component is exercise, which is a very important part of CDT. What we do generally clinically is we advise and prescribe low intensity exercises considering their nature of chronic inflammatory state. So a low intensity exercise is much more suitable because of their chronic inflammatory state. So just another comment I would like to add. A very important aspect is to set realistic goals before we commence the treatment, especially in patients with lipolymphedema. When they start seeing good reduction initially, which is primarily reduction of the lymphatic accumulation, they tend to expect the same rate of reduction throughout. So setting realistic goals will be the best in terms of compliance as well as their mental health. So these were my comments. I just have two questions to ask Dr. Fabio. So my first question is, what is the criteria to decide if the patient will receive conservative treatment or surgery? And my second question is, what pre-op and post-op care in terms of self-care do you incorporate in patients who undergo surgery? Thank you.
Okay, thank you for the comments. What I believe is that every patient has to do the conservative treatment. That's the starting point. And I believe that Dr. Gabriela is right. So if we have a good result with the conservative treatment, it's okay, because in fact, it's impossible to do the surgery in 10% of the women of the world. So no health system is able to do that. And I believe that is almost a question of philosophy also, that we have to be responsible for our health. So eating well, doing exercises is something that's important for all of us, especially for this kind of patients. So if we have a good result with the conservative treatment, I believe that's it's okay. One point only is that there are some triggers that are not in the hand of the patient. For example, pregnancy, or for example, menopause. So even if a person is very disciplined with diet and exercises, one day she may get pregnant. One day she will have menopause, and then maybe she will get worse of the lipedema even with this effort. So, but answering you, doctor, I believe that everybody has to do the conservative treatment, especially the lipedema patients, but even us. You know, eating well, doing exercises, this is essential.
Okay, thank you very much. I also have two questions from the attendee. The very question from Josefina Carvalho. She mentioned, is the lymphatic damage seen in patients with lipedema due to microaneurysm of the lymphatic vessel due to obesity, or is it due to disproportionate adipose tissue? What's your answer, Fabio?
Well, good question, and I don't know, in fact, that the comprehension of lipedema is not fully understood. So yes, there is the lymphatic damage. We see also microaneurysm on the biopsy, but we do not know if what's the beginning. Is the fat damaging the lymphedema, the lymphatic system, or is the microaneurysm of the lymphatic system enlarging the fat cells? So we see these two phenomena together, but we're not sure what's the beginning of the disease. But yes, advanced lipedema stage 4 has the lesion of the lymphatic system, but sorry, it's nothing that I do not know the answer for sure yet.
Okay. The second question from the attendee is from Angela Belinsky. Her question is, has any research reported that lipedema start at a certain age? That's a very good question.
Yeah, it's a very good question. And what we usually see in the story of this patient, it starts in adolescence. So it starts with the hormones. This is the first trigger. So usually the child is okay, but when the girl is 12, 13 and starts having hormones, so that's the first trigger for the disease. So that's why it's very, very rare to affect men. The lipedema doesn't affect men because it may have the genetic problem, but doesn't have the hormones usually. So
and one final question from my side. There is a new technique, as you know, Fabio, which is laser lipolysis, where the technique is you put laser fiber under the skin using diode and Nd:YAG, and you get lysis to fat cells. They said the advantage that it also encourage collagen deposition, so prevent skin wasting. So I know that you are experienced in liposuction. Have you used this technique, or do you think there is a future of laser in lipolysis?
Yes, of course. Yes, there is a very good paper in the world laser because it may reduce the fat, laser reduction, and also to shrinkage the skin also. So it's I believe that laser is a very big tool for us to help these lipedema patients, especially the surgery on the tights.
Excellent. Thank you very much. I hope we cover a question for attendee and for panelists, and we're all eagerly waiting for the great lecture by Professor Thomas Wright from United States. And thank you very much, because I know it's early morning in USA, and we're eagerly waiting for your lecture, and you can start.
Okay. Wait. Hold on 1 second. I'm trying to share here. Shit. Okay. I'm trying to get in the slideshow. Can you see my screen? Is it? Are you seeing the
we see it in the presenter mode.
Okay, all right. Then let me see if I can switch. Let me hold. My apologies.
That's all right. It's all right. Take your time. I just would like to announce that we have more than 100 participants, and the social media is full of attendee to this lecture. Now we can see your presentation, one large full screen. You can go ahead, my dearest.
Okay, thank you. Thank you. And thank you so much for the invitation and to be part of this this august and very distinguished panel. And I'm learning lots, as well as have a little to share. So just talking about compression, and compression in lipedema is poorly understood and not as well implemented as we want. So we're and I do have, these are my disclosures. I have had some support for educational talks and research. So the benefits of compression in lipedema are it helps smooth cuffs and lobules, improves mobility, decreases pain, has anti-inflammatory properties, improves venous and lymphatic function, which improves the health of the skin, and helps maintain the benefits of MLD, pumps, and surgeries. This is by a study by Atan, and he showed decreased pain.
Thomas, we can see your adjustment setting for Zoom, and that's it. That's it. Now we can see your screen full. Okay.
I'm sorry. I'm so sorry.
Yeah. No. It's, every part of your slide is very important to us.
Yeah, so this study showed that just compression, different modalities of compression and exercise decreased pain in lipedema patients. And hold on 1 second, okay. And then he also showed in 2021, his study showed that the decreases leg size in lipedema. And then this is a study I did where we were looking at just measuring volume by calf circumference measurements. And we showed about a 2% decrease with compression, and then adding pneumatic compression pumps. We in some areas we doubled it. However, surprisingly, it actually with the compression pump, we actually did have a slight increase in the hip measurement, which was unexpected. And then in the study, we also looked at bioimpedance, and just a little introduction about bioimpedance. So bioimpedance is a minute electrical signal that goes through in it's at various frequencies. High frequency goes through everything, and lower frequency just stays outside the cell. And so with that, we can kind of we can measure and then when we put the electrodes on the feet and the hands, we can measure it in segments, and so we can see the intracellular and extracellular water that way. And in the study, we did see that the extracellular to total body water, which is essentially the water outside the cell versus all the water, decreased with compression in the lipedema patients. Now, the delta was just 0.007, but that's actually pretty close to the change you would see between a normal limb and a limb with lymphedema. So just to give you that perspective. So again, I'm back to this extracellular water. That's going to be that's your plasma, your interstitial fluid, and your lymph. But your plasma volume is tightly regulated. So basically, those extracellular waters are your interstitial fluid and your lymph changes. So there's evidence of interstitial edema in this study and in other studies. So I really think of lipedema there's a continuum of the lymphatic function is on a continuum with actual lymphedema. And so if you understand that and understand the other benefits, yet only 70% of lipedema patients regularly wear compression. And that's from a study by Lisa McIntyre. And though in that study, they also, the ladies who did wear it said that compression, they felt supported, it reduced pain, and they also reported improved mobility. So, why is the disconnect? Well, as Dr. Reddy already pointed out, that it takes work to get compression to work. It has to, as she suggested, starting low and gradually improving, gradually increasing the strength. Sort of what we call a work-in period can be very helpful. So because as their legs are tender, sometimes just going to the super strongest, the most strongest compression may actually be too much for them, and also going over proper donning, and then they have unique shapes, and so they sometimes you have to have not just custom fit, or sometimes you have to have, we do a lot of knee highs and capris, those who have very large thighs, but maybe not as large calves, and those sort of things. Just lots of different ways to make it work for the lipedema patients. That's just and it really should be medical grade and graduated, because a lot of the ladies are where just they'll say like, oh well, these are some athletic thing, oh, it gives me compression. Well, a lot of the stuff isn't really medical grade and graduated, and we do really find the biggest benefits with the medical grade. And then the types, and so circular net, so the circular net is least expensive, and it works well, but it can get caught in cuffs and lobules. Flat net obviously is less likely to get caught in cuffs and lobules. And then there's the weaves. There's several Italian manufacturers that make great weaves. And then the Velcro appliances. Those have great working stiffness, and but they are heavier and expensive, and sometimes need adjustment. So now this, so very much like Dr. Fabio, Dr. Kawamoto, we agree in treating this comprehensively, and first approaching this as with conservative treatment. And this was actually borrowed from Dr. Amato with his permission, is that we have them focus on triggers of their inflammation in diet, and try and because there is a cyclical nature and of the lipedema inflammation, and compression and diet are anti-inflammatory. So with the compression and diet, we try and decrease those triggers and improve their life with that. And then that really should be done before we do any surgery, and because obviously you don't want to do surgery in the middle of an inflammatory peak. It's theoretically could worsen symptoms. And then I just want to invite everybody, all the listeners, and about the Lipedema World Alliance is having a Congress in Potsdam, Berlin, in October 5th through 7th. So anybody interested, this is the official invitation. Thank you very much for your attention.
Excellent. That was a great presentation, and thank you very much. And I'm sure it will trigger plenty of questions from Fabio and from our co-panelists. But let me start by my co-moderator, Tracy. Do you have any question or comment, Tracy?
I do actually. Thank you, Dr. Wright. That was a really interesting presentation. I've certainly picked up quite a few things that are now turning the cogs in my mind as I go on. But you mentioned about using the IPC treatment for the patients, and you said that you found that there was an increase in the hip area. And given that you were talking about the interstitial water, etc., did the patients just wear thigh-high garments, or did they wear like a pair of trousers? And would that maybe have had a bit of a difference in what you found?
Yeah, great question. And they were in compression from their feet to their at least the forefoot to their waist. So the compression garment, I don't think was. I think that what we saw there was the intermittent pneumatic compression moved some of the fluid from the legs to the hips, and but. I can't, we didn't have any way to prove that, but that's my theory.
Thank you. That's just where I was sort of coming from. Was it more a shift of fluid rather than anything else that had caused that increase? Thank you.
Okay, so I will take the two poll question, and then we have a question from Fabio, and we have another question from Dr. Reddy. So the first poll question, what advantages does compression therapy have to lipedemia? reduce swelling, enhance movement, it helps to stop more tissue damage, or all of the above? So this is a very small question. And in the meantime, let me have a quick question to Mr. Thomas. What is the inflammatory marker do you think is the best to judge inflammation in lipedema?
Wow. I don't know that there is it's not been identified. I don't, I've looked at CRPs and things like that, and I just, I don't know. It's a great question.
That's all right. So I can see that 79% got the answer correct, which is all of the above, which is nice. And the second poll question, in whom should compression therapy never be used to lipedemia? And this is very important. Those who suffer from a skin disorder like eczema or psoriasis, those who experience circulation issue, individual with latex allergy, or all of the above? That's an important question, important understanding. And let me remind that hopefully at the end we'll have from each of the speaker and the panelists a take-home message, because this subject is not really well studied. There is not much worldwide consensus about it. So hopefully we'll try to grasp what is most up-to-date into that field from this global expertise opportunity. So I'm just filling the 30 seconds that is for the answer of this question. Okay. Well, it's a kind of it's a mixture, yes. It's a mixture, yeah. Some people who have seen ischemia, so these are 34% said ischemia. Others who have seen psoriasis, or maybe they are dermatologists, they will say 17%. Well, the latest one is allergy latex, which is only 3%, but again, majority got it correct, which is all of the above, 45%. Thank you very much, and let me put the mic to Fabio, and after that, ready. Fabio, your question to Thomas.
Thomas, I believe that you have a big experience with compression. Does the patient has to do it for the whole life, or do you believe that it's important in the beginning of the treatment and then she may be freed sometimes from the compression?
That's a great question. And I actually agree. I think you mentioned this, and I agree with you that they are likely, there's no actual cure for lipedema, and I do believe that they will need some compression for their whole life. Now they may need less, but I still think that it's that they should be encouraged to continue it their whole life.
Okay. Thank you.
Okay, Dr. Reddy was raising her hand. If you have a question, Dr. Reddy, for Professor Thomas. Yeah.
Thank you, Dr. Thomas, for such an informative presentation. Well, I am a lymphedema therapist as well as I'm a very proud women's health physiotherapist. So from a women's health physiotherapist perspective, I have a question regarding compression during pregnancy. So are there any modifications required with respect to compression in a patient with lipedema who is also pregnant? If yes, what are those modifications? Thank you.
Well, they would certainly later on in the pregnancy, they're going to need a maternity style compression that's going to have increased, increased size in the abdomen, and some there are sometimes that cannot tolerate it in late stages of pregnancy, but otherwise we still encourage it if they become pregnant.
So what about the compression class? Do we encourage class 2 compression itself, just like other lipedema patients, or do we prescribe class 1?
Oh, that's a great question. You know, I'm not I generally early on, I think they can still do the class 2 and maybe I actually don't know if it needs to be adjusted. I would be interested in your thoughts.
Okay, so my dearest Mrs. Faber, Gabriella, do you have any question to Professor Thomas?
Yeah, thank you very much, Tom, for this presentation. Again, I go along with I think everything you said. I would like to agree with you that it is important to choose the right material. And it's not always necessary to start off with platinate, but you know, in a young patient with rather slim legs, this is, by the way, one point that I would like to stress. We've seen those cases by Fabio, and they were really impressive. But we have also got young patients, slim patients. The legs are not really, I mean, in jeans or trousers, you wouldn't even see they've got lipedema, but they've got the pain. So the pain is the symptom that's most important and must give us reason to try to treat those patients. I always, I'm not happy about reducing it to the fat volume, because on a visual analog scale, and also there's an ongoing study in Germany by pain researchers. They found that the pain does not depend on the size of the volume, but it you know, it's independent of that. But coming back to my point, so in that young patient with more or less normal proportions, you could start off with round knit stockings. But as you said, Thomas, afterwards, when there are lobules and folds, you need to find the proper flat knit. And we in Germany were in a very privileged situation, I think, because compression is fully covered by the system. So there's no problem. And we as doctors decide which type of compression. I have a question for you, Thomas, before I go on with my comments. I would like to know in that by the impedance study you did you record the hormonal phases?
Can you say?
You know, in that bioimpedance study you did,
yeah.
Did you take note of the cycle, of the hormonal cycle? Because I do it. All my patients who are on nutritional therapy get a bioimpedance analysis every few weeks, and I've discovered that there's huge difference whether they're menstrual PMS or after or at ovulation, and that is why I find it so difficult to judge bioimpedance. You know, I've got a similar system and I really like it very much, but very often you find changes that you can't really explain, or maybe you can explain by the hormonal situation. So did you take note of that?
So no, we didn't. And that's a great point. I think that you know, the only thing I can say is that we did do it at monthly intervals, so we were consistent at least in the calendar month. But I mean, not every lady is regular exactly on the calendar, but many are, and so that might yeah. But that's an excellent point.
Mm-hmm. I'm trying to take note every time which day of the cycle they are on, but so yeah, the next comment I've got is about inflammation. You know, Tom, there are two debates raging. The one is about the interstitial fluid, and I found it very interesting. You found, as Tracy said, there's an increase at the hips, and I think that might due to the you know, the sort of lifting, wrong expression, you know, moving the interstitial fluid.
Yeah.
I'm a strong believer in interstitial fluid, and again, there's strong opposition to that. I'm a huge fan of GAGs because they can contain a lot of fluid without us being able to see it online on the ultrasound. You know, I did a study myself, and we found we couldn't see any fluid on the ultrasound, but we don't need to see it. And I have many patients who report they can't pull up their genes at night, the same genes they were perfectly able to pull up in the morning. And we're actually just starting a study, a multi-center study. We've planned it. We have not really got going, but I do hope we will. We want patients to measure their thighs in the mornings and in the evenings, because this is something that needs a position from the Black Forest. They say there's no fluid there, and there is, otherwise you can't explain that. You know, so I think that is something we should all try, and we should try to research, to do more research on the fluid, really, because there's this strong opinion there is no fluid in lipedema. It's called there's no edema in lipedema, but maybe we need to call it, Thomas, I think we are going to meet at the end of August and we'll discuss that. I think maybe we need to find a new term for edema that is not in the lymphatic system, or that is not, you know, you can't, exactly.
Yeah,
Last,
that's a very important point. We have made also variation between morning and evening regarding venous reflux in nurses, and we found that 50% of them develop reflux during the evening, which is not in the morning. So even the diurnal variation from the venous side of things also confirm your point. So this is a good study to do.
But that is easy to explain. We call it orthostatic edema, which we don't see. We don't see that on the ultrasound either, by the way. But I don't think that can explain the swelling at the thigh. You know, orthostatic is below the knee, and how can, if it was orthostatic purely, it would probably go down all the way to the ankle. I've got one last comment on the inflammation, because you asked. I have been trying to look at CRP. I can't, it's inconsistent completely. There is a study group in Germany, Leipzig. They seem to have found a slight elevation in CRP. I can't with my patients. There are studies that found pro-inflammatory cytokines, like interleukins and of course macrophages called what are they called? Crown-like structures. As our chief anatomist, Erich Brenner, maintains that does not yet prove inflammation. It's pro-inflammatory, but it doesn't. There hasn't been the proof of proper inflammation. So I think that's another field of research that we have to have in mind. And as Tom said, we founded the Lipedema World Alliance last year, and I think there's a lot of expertise among these members, and we are going to try and motivate our members to go on with doing research. I think that's most important. We need facts. We don't need opinions. We don't need paradigms. We need facts.
We do.
Yes.
Thank you.
Yeah.
Excellent. That is great. And I think there is one of the attendee raising his hand. I think he wants to put his question verbally, which is Adrienne Soraya. You can go ahead. I think you can unmute yourself and ask a question. Adrienne Soraya, who has raised his hand from the attendee, you can ask your question. I'm sure the moderator will open your mic.
See if I can find.
In the meantime, I would like to announce. Yes, hello. Yes, you can speak. Yes, we can hear you now.
Thank you. I'm Dr. Surya from Indonesia.
Welcome.
Can you hear me?
Yes, we can hear you well. Go ahead.
I like to ask question from the speakers. Is there connection of insulin resistance and lipidemia? Because now insulin resistance is a common platform for diabetes, hypertension, also Alzheimer, also cancer. So do you think lipidemia also has that factor before they go so serious? So in the early stage of lipidemia, can they then prevent by diet that is no sugar? Thank you.
Okay, so I will get you all the expertise. I will get you 4 answers to your question, our 2 speakers, our 2 panelists. So Fabio, you can start.
Well, I'm not sure about the answer, but what I believe, and this is my personal impression, is that there is no relation between these diseases, because it's interesting to see that although these patients have a lot of amount of fat on the legs, I do not see usually metabolic disease here. So they do not have diabetes, they do not usually have high cholesterol, they do not have high pressure. So what I believe that interestingly, there is no relation between this metabolic disease and the fat of the legs. So I believe there is no relation, but this is my personal opinion.
No problem. Dr. Thomas?
Yeah, I actually think it's maybe the opposite. I think the gynecological fat in the hips and thighs may actually be protective or more insulin sensitive. But you know, I think if a secondary obesity occurs, then I think they get insulin resistance just like everybody else.
Yeah, Gabriella?
Yes, I fully agree. I looked at my own patients and I found that if you match lipedema patients with obese patients by their BMI, which one shouldn't do, then lipedema patients always have better metabolic values. And there is a study group in Saxonia in Leipzig. They did a very comprehensive study and they found that there was less risk for insulin resistance and diabetes in lipedema. As Tom said, it's the female fat areas that seems to provide a sort of protection. But when there is abdominal obesity, and that is the case in many women, then that advantage gets lost. And then there's another aspect, which I think is why my favorite diet, the ketogenic diet, is still works. And that is the diet that reduces insulin as much as possible. We think that the lipedema adipocytes are different from ordinary adipocytes, even in the gynoid regions, and they probably they are less ready to shed their fatty acids. So even in a normal, at normal levels of insulin, they are still able to store fat, or they're able to store more fat, and they are not able to shed it again. So although there's no insulin resistance, there is a stronger answer to lower levels of insulin. That's my opinion, and I think there is some scientific evidence for that.
Okay, and Dr. Reddy?
Well, I'm not sure of whether insulin resistance per se leads to lipedema, but I believe in the opposite, the other way around. That is, lipedema can lead to a sedentary lifestyle due to their difficulty in leading a normal active lifestyle, and that may lead to insulin resistance.
Right.
Yeah.
That's a point.
Also, Tracy, she's an experienced NHS head nurse for a long time. You remember, Tracy, when we see a young diabetic injecting insulin, we see lipodystrophy, which is atrophy to lipid in the local site of injection. So this hormone is really fascinating me. So what's your answer question, Tracy?
I really don't have a full answer on it. I think, again, the discussion is, you know, what comes first, that chicken or egg sort of situation, isn't it, really? I do see, I've had some diabetic patients who I have seen much more distribution around that area, but again, that's just a clinical observation. There hasn't been any studies on that, but I would be, you know, would welcome a lot more sort of comment discussion around it, because I do think this is a topic that, you know, we can't ignore.
Absolutely. Yeah.
In it,
Okay,
really.
and we have plenty of questions. I'm sorry to exhaust you, Thomas. Yes.
I have few comments about Dr. Wright's presentation, if I may.
Yes, please. Please go ahead.
Yeah. So first of all, it's about the style, the type of compression garment that is used. So I personally feel that pantyhose is better than either knee-high or thigh-high garments, especially for various reasons, but especially because it gives a gradual transition. And when we use either knee-high or thigh-high garments, it ends abruptly and it also tends to roll down. Another reason is it does not give a proper support to the an anchoring support to the limb. So I feel pantyhose would be the right garment. And another comment would be, owing to the already existing tenderness in the extremities, the affected extremities, even if there is slightest gathering of the, I mean, if there is any wrinkles in the compression garment, that could lead to pain, which would ultimately affect patient's compliance. Therefore, to choose the right garment and right fit becomes very important, along with teaching the patients to master the art of donning and doffing also is very important to ensure the compliance. So this was my last comment. Thank you.
Can I just add into that? I think, Dr. Eddy, definitely, I think fit, material, comfort is all really important in actually getting our patients to comply with wearing compression. And it's often that very problem that actually puts them off wearing the compression for life. And that's when we start to see more problems. So I would definitely agree with those comments. Dr. Thomas, I don't know whether you want to comment.
Yeah, no matter how much of evidence-based multidisciplinary approach we give, at the end of the day, if the patient is not compliant, I feel we're not going to achieve the end goal. So yes.
Yeah.
Thank you.
Thank you.
Yeah. So my response is thank you. That I agree with you. And pantyhose are the best in that they give the complete coverage, but sometimes we have some people that are so disproportionate, have such smaller calves, and that we will do a capri and layer that with like a knee high and with an overlap, and we do find that can work. Like in Dr. Kawamoto's the warrior at the end with the very large hips and but relatively smaller calves that he showed, that she would be someone that maybe wouldn't fit in a regular pantyhose unless it was custom made.
Yeah, absolutely. So we got here an important question from the attendee, from Luis Patiolo. His question is, for lipedemia, what class compression do you use? Would you consider 40 millimeter mercury to this patient? Can you use a higher pressure as with lymphedema? I think this is an important question. So I will put it to Thomas and Fabio. Start, Thomas.
Well, we generally use class 2 or like 20 millimeters of mercury to 30. Now, if they have secondary, if they have a lot of secondary lymphedema, and then we might go up, and we do go up to 30 to 40, but generally we use class 2, 20 to 30 millimeters of mercury.
Okay, and Fabio, is it the same?
Yeah, I agree with Thomas. We usually start with 20 to 30 millimeters. And it's rare to see the lesion of the lymphatic. So we do not use higher compression garments usually.
Yeah, okay. Here we got a question from Lucy Millikan. Can you please clarify the question about who compression should never be used on? Was anyone with circulation issue should never be used? I think because maybe this question was not elaborated. If you have problem with vascular, like arterial insufficiency, or you got ischemia and you have used improper compression, you can get gangrene. So this is, I think, what we meant by this question. So if you have an arterial insufficiency, it's one of the contraindication to compression. We got another question from Edwin Stefan. Please share experience with wraps for compression. Would your compression therapy help instead of stocking? So this question to Thomas.
So sometimes, I mean, we do wraps occasionally, but more often we use just the compression garments. But and sometimes we use reduction kits as well. But the complete decongestive therapy with the sequential wraps, we use that less often.
Okay, Fabio, do you like to add your expertise to this question?
Yeah, it's rare to use wraps, but I see a paper that, especially after the surgery, because after the surgery, the volume of the legs shrinks a lot and very fast. So wraps would be an option for us to adjust the garment during this post-op period. So maybe it's a good idea.
Okay, so I will take
down the edema with that. Yeah.
Yes, please.
Yeah. No, I was just going to say, because that way then you can chase down the sizing of the limb without having to constantly remeasure and get the hosiery for the patient. So yeah.
Absolutely. So I will take the last question, which is from Els Brover. Remark regarding compression and pregnancy and skin disease. Compression class are not the most important, as we have a standard in the world. Those for standard differ in the amount of millimeter mercury. The material is more important, and in pregnancy, you don't want much compression on the belly area. So I think it's self-explanatory question. Do you like to add a comment, Thomas?
No, I think that speaks for itself.
Yeah, that's true. I agree. So because this topic is very interesting, and because we don't have evidence-based proof, the class A evidence of what is the best scenario to do, I would like to close this meeting with a couple of minutes to each of the speaker, my co-worker, my co-moderator, my excellent panelist. What is their views, or what is the conclusion that we would like to send to the doctor? Because we in the MOH Hub would like to be a global enforcing this opinion and helping them to get a universal consensus. So let me start by Fabio. If you like to, what is take-home message we have from this webinar?
What I'd like to say is that we are working worldwide in the awareness of lipedema. And this is so important because what I see every day here is a feeling of guilty, a feeling of not having hope in this situation. And I'm very happy with what's going on worldwide in terms of this. So I'd like to say that there is a hope for these patients. And I believe that we're just starting the work. So the lipedema patients may have hope, and they will get better every year because there are more technology, more studies, more doctors dedicating this time to this. So I believe that's going to be a completely situation about lipedema patients in 10 years. So
okay, that's great. That's great. So future is good. Thomas.
Yeah.
Well, I think the overall message is that this is this disease should be treated comprehensively with diet, compression, and surgery. That it requires a multidisciplinary, many medical professionals, nurses, doctors, physiotherapists, and nutritionists, and that with these treatments, we can have significant improvements in the quality of life of these individuals.
That is excellent. And Gabriella?
Sorry, I was muted. Yeah, I agree. And maybe if one thinks back 10 years, that gives us hope, because a lot has happened during actually the last 4 or 5 years. So I trust that there will be new discoveries, new developments. My take-home message is the ultimate goal, if you want to treat, treating lipedema patients, is lessening the symptoms, reducing the pain. Whatever we do, whether we treat conservatively, that, for instance, is important in choosing the right compression. They don't normally need the strongest, the hardest, but you have to reduce the pain. And that's what's done through compression, through MOD, through nutrition. And that is what we, as all of you said, comprehensively together. It needs a village to raise a child. It needs the whole global community of experts to treat lipedema.
Okay.
Excellent. And Dr. Reddy?
Well, when it comes to take-home message, I have precisely 5 points. So the treatment should be always multidisciplinary, as reflected by all the speakers and my co-panelists today. Appropriate and adequate counseling regarding the nature of disease and its prognosis should be included. A realistic goal setting should be followed. Mental health should be equally considered as much as their physical health. And last but not the least, the treatment should progress at a rate that is not too overwhelming for the patient, so as to ensure the compliance. Thank you.
Excellent. And my excellent co-moderator, I heard you have a question to answer the wrap as well, and you can give us your fantastic take-home message.
Yeah, with regards to the wraps, definitely, I think there is a use for that after the surgery. Not so much, I think, as an ongoing in terms of how people will manage to mobilize. I think we need to get something that's going to encourage them to move better. But definitely after surgery, I think there is a place. My take-home message really echoes quite a lot of what has been said here, in that we do need a multidisciplinary approach. We need to be able to get compression that is comfortable, that the patients are going to feel cosmetically happy in. And, you know, the layering, as Dr. Thomas said, we often will do that to make it easier for them to apply the garments, actually using lots of different options like zips, etc. It makes it easier for the application as well. And I think as much as we can do that from an industry point of view, then we can help the clinicians, we can help the patients out there to become more compliant, concordant with their treatment as well.
Excellent. Thank you very much. And I'm really grateful and happy for your impact about this significant worldwide disease with different multi-continent approach to it. And I hope to invite everyone to MOH platform, either the website or YouTube, to share your comment. I think there was a consensus about dealing with lipedema in Europe, which was 2 years ago. A lot of things have really changed, and hopefully with the current research from Gabriella, from Fabio Smith from India, all of this will put a hint on it, and hopefully with this document, it will give you the best clinical advice. And I obviously also would like to invite you, if you have a difficult case and you want to know which type of compression you need to use, which size, again, I would like to add you to join this general continuous 24-hour conversation. I hope you enjoyed the MOH talk today, and I hope it is of benefit to you and to your patient. I am sure it will play a lot in our clinical practice. I would like to thank very much my co-moderator, Tracy, for your time and your effort. And I would like to thank very much the great speakers from Brazil, from USA, to show the cutting edge technology with all tips and tricks. I'm very grateful to Gabriella. I know she had a lot of family commitment, but she insisted on attending this webinar, and that is very grateful. And Dr. Reddy from India. I'm very thankful to the MOH team, Dr. Mahmoud Al-Ghadban, Dr. Khalid Zidan, for giving this international arena. I wish you all the best. I promise you to get you the next time the most cutting edge vascular knowledge available on the planet. I wish you all the best.
Thank you.
Thank
Bye,
you.
everyone.
Okay.
So Tracy, do we leave now?
I think so. Yeah, I think we can just leave now when we're
Okay.
ready. Yeah. Okay. Thank you so much. I really
Thank you
enjoyed-
so much for the opportunity. I really appreciate Sigvaris for having me today.
Yeah,
You're welcome. Thank you.
Thank you so much, Dr. Sean.
thank you.
Thank you.
All
Thank
right.
you.
Have a great day.
You
Bye-bye.
too.
Bye.
Bye. Bye.
Thank you.